Allison Young, who is a junior investigator, a student of Miriam Welgampola. Miriam recommended that Allison does this lecture because she just defended a thesis on a very similar topic, and she would be very appropriate for this lecture. So they recorded, since they're in Australia, they are not available. It's probably, God knows what time it is over there right now, but they're not available for panel discussion. We'll try to, again, answer the questions the best we can. If needed, we will forward to them. We can start.
Hello, my name is Allison Young, and I'm a research audiologist at the University of Sydney, and I'm pleased to present to you today our recent findings on the Ictal characteristics of common and uncommon vestibular disorders on behalf of Associate Professor Miriam Welgampola. In our 2019 study, we recruited patients who reported recurrent vertigo. We taught the patients how to record their own eye movement during an episode at home using a small portable set of video Frenzel goggles. Our focus was to study the ictal nystagmus characteristics of those with Meniere's disease and vestibular migraine as close to the onset of the vertigo as possible. This instructional video demonstrates the routine these patients conducted at home. At the beginning of a vertigo attack, the patient sits on a bed or a sofa and puts on the video goggles. They then describe their dizziness and record in the upright position. If the patient is well enough, they're instructed to lie supine for 30 seconds and on either side for 30 seconds as well. If the vertigo lasted for an hour or longer, the patient was advised to make short recordings, only sitting upright in intervals of 15 minutes. We recruited over 200 patients over 6 years, including patients diagnosed with vestibular migraine, Meniere's disease, and benign paroxysmal positional vertigo, vestibular paroxysmia, episodic ataxia type 2, and other less common causes of vertigo. This first video shows a woman with left-sided Meniere's disease at the onset of a vertigo attack. At first, there was high-velocity left-beating torsional nystagmus, which is considered to be the paretic phase, beating towards the affected ear. Then, over 2 to 3 minutes, the nystagmus gradually transitions to downbeating. At this point, after 50 seconds, the nystagmus is nearly purely downbeating. However, after over 2 minutes, the nystagmus has switched to right beating. This second video represents a very common pattern of nystagmus from a dizzy patient with vestibular migraine. You can see that the nystagmus is almost purely horizontal, but it differs from the patient with Meniere's disease due to the slower velocity and the lack of a torsional component. When the patient lies down, the nystagmus increases in velocity slightly, which is also a common finding for this group. Here is a nystagmus trace, which represents common findings in these two diagnostic groups. In the patient with Meniere's disease, the nystagmus is high velocity and horizontal, which does not alter significantly when lying down or in either roll position. However, the patient with vestibular migraine during an attack of vertigo shows lower velocity or negligible spontaneous nystagmus while sitting upright, but shows an increased nystagmus velocity when lying down, also demonstrating a positional direction change with respect to gravity, apogeotropic here as the nystagmus is beating away from the earth on either side lying position. Occasionally, patients with vestibular migraine will also show spontaneous vertical nystagmus, in this case upbeating, which is very rarely seen in patients with Meniere's disease. Here is another video of a vestibular migraine patient with spontaneous downbeating nystagmus, also an uncommon finding in Meniere's disease, unless it's transitioning from one side to the other. Statistical analysis found that the velocity of spontaneous ictal nystagmus in those with vestibular migraine and Meniere's disease were significantly different, with MD showing much higher velocities overall, shown in the top left box. In the center box, you can see that patients with MD were significantly more likely to demonstrate a spontaneous direction reversal of horizontal nystagmus than in those with VM. And in the right box, it shows that the nystagmus in patients with MD is almost always horizontal, while those with VM in red may display vertical or horizontal spontaneous nystagmus, with about 25% showing no visible nystagmus in the upright position, even when they report feeling dizzy. Separating BPPV from persistent positional vertigo, such as in those with VM, seems straightforward, but occasionally it is difficult to elicit the BPV in the clinic, and then it must be investigated further. Here's a video of a patient who reported positional vertigo, but in whom we couldn't elicit the BPV in the clinic. However, she recorded herself lying down at home on the video goggles, and it showed the common pattern of paroxysmal torsional upbeating nystagmus, indicative of benign positional vertigo in the left posterior canal. Here is another nystagmus diagram of the BPV rise and fall crescendo pattern compared with the vestibular migraine pattern where the nystagmus is persistent in all lying positions. Now I'll share some Ictal videos of rarer causes of vertigo which were captured by our patients on the home video goggles. This video demonstrates a classic pattern of vestibular paroxysmia. The patient recorded her eyes for 8 minutes while sitting upright and captured 2 episodes of spontaneous torsional nystagmus, time-locked with brief episodes of vertigo. Vertigo. The MRI demonstrated a large right meningioma, which was found to be the cause of the paroxysmia. In this home video, a patient who reported recurrent brief positional vertigo demonstrated a BPPV-like torsional paroxysm of downbeating nystagmus after lying flat, which was found to be caused by a superior semicircular dehiscence, presumably becoming plugged and unplugged in the upright and lying positions. This video demonstrates a rare case of sudden onset recurrent vertigo, 3 years post-cochlear implant in a man without a history of vertigo. The initial cause of hearing loss was sudden sensory neural hearing loss of unknown origin. The home videos showed spontaneous ipsiversive left beating nystagmus, followed by right beating contraversive nystagmus 4 days later. A diagnosis of post-CI delayed endolymphatic high drops was made. In the last home video example, a patient with episodic ataxia type 2 demonstrates persistent downbeating nystagmus during an episode of ataxia, which lasted for days. In addition to the home video monitoring, we concurrently began a study of event monitoring in the emergency department of the Royal Prince Alfred Hospital, University of Sydney. The video monitoring system for this study was a more robust design, using a laptop sitting on a wheeled trolley, and was named the Dizzy Cow. Emergency physicians were taught how to record the ictal nystagmus of patients admitted to the hospital. Patients presenting to the emergency room with acute vertigo were given a structured questionnaire, a nystagmus video recording, a video head impulse test, audiometry, and the HINTS protocol for stroke detection. Over 400 patients were recruited over 6 years, and their results were compared to those of other emergency room patients with vertigo, but who received normal standard of care without the extra structured vertigo questionnaire or nystagmus recordings. Of the patients recruited, the two most common presentations were a first ever acute vestibular syndrome and patients reporting recurrent spontaneous vertigo. Other presentations were classified as recurrent positional vertigo and less commonly an acute transient vestibular syndrome and chronic disequilibrium. Of the patients presenting to the ER with an acute vestibular syndrome, the two most common final diagnoses were vestibular neuritis and posterior circulation stroke. The other less common diagnoses included VM, labyrinthitis, central vertigo, and Meniere's disease, with a small group left undiagnosed. Notable is that posterior circulation stroke accounted for 1/3 of all cases of acute vestibular syndrome in the ER during the study period. Most acute PC stroke patients displayed some degree of spontaneous nystagmus upon admission. The nystagmus observed in the group was horizontal in the large majority, with vertical and torsional nystagmus occurring but less frequently, and 34% of these patients displayed gaze-evoked nystagmus only. So using the nystagmus information gathered by the DizzyCow, we wanted to test whether these characteristics could be used as a diagnostic indicator as to the cause of vertigo. It was found that the velocity of spontaneous nystagmus in patients with vestibular neuritis was significantly faster than in those with PC stroke. However, those with stroke and vestibular migraine showed similar nystagmus velocities. It was also found that the nystagmus fast phase direction was more diverse in stroke patients than in both those with vestibular neuritis and vestibular migraine, which was almost exclusively horizontal, while stroke patients often displayed ictal vertical nystagmus as well. Here is a video of a patient who was admitted to the ER with a right vestibular neuritis and who displays contralesional left beating nystagmus with a small downbeating component. Here is another video of a patient with left vestibular neuritis, which follows the same peripheral nystagmus pattern with right beating contralesional nystagmus with a torsional component, which is decreased slightly in the left gaze and is increased slightly in the right gaze. Here we see a video of a patient whose MRI shows a right anterior inferior and left posterior inferior cerebellar artery territory infarct, and who is showing spontaneous right beating nystagmus, which remains stable in both gaze positions. This example shows a patient with a right pontine stroke who displays purely torsional spontaneous nystagmus. This example shows a patient with right pica territory stroke and displays ipsilesional right beating nystagmus in all gaze directions. Contrary to the previous pattern of right pica stroke, this patient displays left beating contralesional spontaneous nystagmus. Moving on to the episodic spontaneous vertigo patients admitted to the ER, following investigations, the majority were given a final diagnosis of vestibular migraine, with the second largest group remaining undiagnosed and the third largest group receiving a final diagnosis of Meniere's disease. Other less common cases included vestibular paroxysmia, autoimmune inner ear disease, and encephalitis. In the vestibular migraine group, half of all patients showed no spontaneous nystagmus at the time of admission, while 38% had positional nystagmus only, showing a variety of patterns. Only 9% of vestibular migraine patients demonstrated spontaneous nystagmus while sitting upright. All patients with a final diagnosis of Meniere's disease demonstrated horizontal nystagmus only. Also, it was found that the nystagmus velocity was significantly faster in MD than in VM patients. When we compared the audiometry results, those with Meniere's disease, as expected, had significantly higher average thresholds in one ear as compared to those with vestibular migraine, who tended to show normal and symmetric results. And lastly, vertical and/or torsional spontaneous nystagmus separated vestibular migraine from Meniere's disease with a sensitivity and specificity of 60 and 100%. In the episodic positional vertigo ER group, most patients were ultimately diagnosed as having benign positional vertigo, with the second largest group having no formal diagnosis. Most importantly, when we compared the intervention group to the controlled dizzy emergency patient group, we found that the study group received a definitive diagnosis in significantly higher proportions than in the non-study group. Areas for future research could involve establishing emergency room event monitors for all dizzy patients, an open access repository of nystagmus and eye movement disorder video examples, and lastly, the availability of commercially made, simple, portable nystagmus recording devices for general use. To conclude, here are a few take-home messages. Nystagmus patterns may help to separate and diagnose vestibular migraine versus Meniere's disease and stroke versus vestibular neuritis. Patients with vestibular migraine do show nystagmus when dizzy, which is faster than those of normal controls without vertigo. Episodic positional vertigo of BPV can be separated from the positional nystagmus of vestibular migraine by its velocity profile. A very small subset of patients who receive cochlear implants may experience a form of delayed endolymphatic hydrops type vertigo, but it is not certain whether the symptom is caused by the implant or the original cochlear insult which caused the hearing loss. Lastly, both patient-initiated home event monitoring and emergency room nystagmus recordings are feasible and may facilitate earlier diagnosis and intervention. Thank you for listening to our presentation, and we would like to thank our funding partners, the Garnet Pass and Rodney Williams Memorial Foundation, and the National Health and Medical Research Council of Australia.